Thanks so much, everyone, for being here. I'm really excited to speak to this audience. I'm Alexia Yakubovich, and I'm an associate prof in community health and epidemiology at Dalhousie, an affiliate scientist with IWK Health and Nova Scotia Health. And I'm going to be speaking today about transforming health system responses to domestic and sexualized violence and the work that we've been carrying out in Nova Scotia. Before I begin, I want to acknowledge that I'm speaking from where Dalhousie operates on the unceded territories of the Mi'kmaq, Wolastoqey, and Besquet-Magadi peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the peace and friendship treaties. Given the subject of my work, I also want to take a moment to recognize and honor the spirits of the missing and murdered Indigenous women and girls. I also want to recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched Mi'kma'ki over the last 400 years. And reflecting on my commitment and my team's commitments, we are working towards dismantling the historic and ongoing systems of oppression and structural violence that disproportionately harm Indigenous, African Nova Scotian, and other marginalized communities. And we're also working on making visible and disrupting the ways in which these systems perpetuate the inequities in domestic and sexualized violence and gender-based violence more broadly that we see in society today. Now, in particular, my research program is focused around strengthening systems responses to violence against women and gender diverse people across the country and around the world. I have a website called www.vawresearch.com. You can go to it directly or use the QR code where we post all of our outputs from our work. That includes peer-reviewed publications, but it also includes an infographic summary for every publication we put out. All publications are made open access. We also do public reports, different video presentations, a lot of media engagement, and more. So if you want to learn more about our work and the different projects, I encourage you to check out this site. The team behind this work includes not only researchers, but also community leaders and advocates, service providers, decision makers, trainees, and women with lived experience of violence. What I'm going to focus on in the time that I have today are three questions. So, why should gender-based violence be a priority for health systems? What is my work in this, and in particular, the embedded research program that I'm leading as an ECR, I guess I should have mentioned. And what are the takeaways for preventing violence and other complex problems in health systems? And in particular, thinking about those problems that may often be marginalized or sometimes categorized as being outside of a biomedical scope of practice, and certainly those problems that require cross-system and intersectoral action. So I'm going to be speaking a lot about violence prevention, but the lessons learned from this work are really applicable across all sorts of complex problems that many of you are working on right now. So, why is gender-based violence a priority for health systems? Well, according to the recent study from The Lancet, the Global Burden of Disease study, intimate partner violence came out as one of the top 5 health risks amongst reproductive age females globally. And intimate partner violence is the most common form of violence against women and gender-based violence. The Lancet actually highlighted on the title page of this issue how, compared to other health problems of similar magnitudes, intimate partner violence has received comparatively less attention and resourcing. And in particular, as well, not just primary prevention of violence, but also how we respond to this violence and meet the needs of survivors. So, this has been demonstrated repeatedly internationally, and it is also an issue of national relevance and unfortunately also of regional relevance to Nova Scotia. In particular, Nova Scotia has the most women who self-report experiencing intimate partner violence among all Canadian provinces, according to our most recent StatsCan data. We also have an annual rate of femicide, which is the killing of women and girls with a sex or gender motive, that is higher than the national average. In part, this includes the mass shooting in 2020, which was committed by a perpetrator with a longstanding history of intimate partner violence and gender-based violence. And the incident itself began with a violent case of intimate partner violence. Following the Mass Casualty Commission recommended that the Nova Scotia government declare intimate partner violence to be an epidemic in this province, which it did in September 2024, which was then followed by a series of intimate partner homicides that led to the killing of seven women by men over a period of 5 months. So unfortunately, this remains an ongoing issue in our province. Most recently, the Atlantic Domestic Homicide Review Network looked at 10 years of data around intimate partner homicide to try and understand where were there opportunities to prevent this lethal violence from occurring. And in a review of this data, they found that the most common service contact that victims had had was health related. And in particular, at least 1 in 4 victims of intimate partner homicide had accessed mental health providers, healthcare providers, or hospitals before their deaths. And this statistic has been repeatedly shown across many years of data that the most common formal service that is accessed by survivors of intimate partner violence or victims of intimate partner homicide are healthcare services. So this represents an important intervention point for survivors who may not otherwise ever access any other formal support to wrap them around with supportive services and help lift them out of violence over time. However, the question is, what is the capacity of the health system to take up this work? And that's where my team has come in, and we recently conducted a needs assessment in Nova Scotia looking at the preparedness of the health system to respond to domestic and sexualized violence. And this work was known as the Interprovincial Violence Against Women Project, or the IPV project. It was carried out across Nova Scotia, New Brunswick, and Ontario. But I'm just going to highlight one of our papers from Nova Scotia, which engaged 1,650 healthcare providers and health professionals, also in non-clinical roles, looking at the extent to which violence was coming up in their work and whether they had the skills and resources to be responding to that violence. And what we found is that nearly 1 in 2 of our participants who were working with patients were seeing domestic or sexualized violence regularly in their work. However, the vast majority of our participants reported they did not have adequate training, whether we're talking about up-to-date training or any training at all around how to respond to violence. They didn't know where to refer to in the community, and they did not have adequate resources at their work sites. So really significant structural and organizational gaps in our capacity to be responding to domestic and sexualized violence in the health system. And so that leads me into what is this embedded research program now? And so we've recently named our project. It's called SHAPE, Strengthening Health System Approaches to Preventing Violence with Evidence. And the work is supported both by my Health System Impact ECR Award as well as an implementation science grant through CIHR's National Women's Health Research Initiative. So we have 2 principal knowledge users in recognition of those 2 streams of funding. One is Nova Scotia Health's Annette Elliott-Rose, and the other is IWK Health's Leanne LaRocque. But the work is really supported by a large number of knowledge users across our 2 health authorities, Nova Scotia Health and IWK Health, as well as provincial government. And critically, we also have a group of advisory and working groups who are supporting this work in all stages, organized into equity-oriented issues. And that includes an advisory of VAW and allied community organizations, an advisory of survivors of violence against women, an Indigenous advisory that's co-led with the Mi'kmaq Family Healing Center, an African Nova Scotian advisory, and an immigrant and newcomer advisory as well. I'm going to speak at a high level about the work that we have done and are doing, and I'm happy to provide more details as people are interested in questions. But generally speaking, we are working on implementing a complex intervention strategy that includes 3 different levels. And the first is the systems level, which is really about building up capacity within the health system in terms of people resources, so identifying people with high level expertise around domestic and sexualized violence, who we call anti-violence champions, that already exist in the health system, and then training up others to take on this champion role, and strengthening the supportive policies that allow them to work effectively within their programs and across programs, and to improve the coordination of work that's happening within the health system, and importantly, coordinating intersectoral work to better support survivors. And so what that means is when violence comes up in a particular program, how do we connect them to supports that exist within that program, that may exist within other programs in the health system, and that exist in social and community services that exist outside of the health system. The second piece is the system clinician interface, and that is around how do we improve routine monitoring and evaluation of domestic and sexualized violence. So one of the things we found in our needs assessment is that very few participants reported having access to or collecting any data around domestic or sexualized violence amongst patients or communities. And what that means is we don't have a ready-made monitoring and evaluation system to estimate the prevalence of violence within the health system, or to see how well we're doing when we implement new intervention or policy strategies. But improving measurement is an intervention in and of itself when it comes to violence prevention, because it means that now we're going to be asking patients about violence that they're experiencing or community members. So we need to do something effective with that information. And so if we're going to be eliciting disclosures, we then have to manage those disclosures appropriately. And so that's where the tailoring to clinical context comes into play, including considerations around, for instance, continuity of care versus episodic care. And then finally, the piece that everybody wants to focus on is provider training. And so provider training is, of course, necessary in order to successfully implement this strategy. But importantly, we can't just train providers without having these structural changes and supportive policies and procedures in place. Now, the programs that we're working with include public health, maternity and childcare, emergency, primary health care, and mental health and addictions, which have all been recognized within the literature as high priority areas most likely to see domestic or sexualized violence. We are also working with a cross-systems program that was set up in Nova Scotia called Violence Prevention, Intervention, and Response, that includes capacity building around intimate partner violence and also coordinates our sexual assault nurse examiner or SANE programs. So we're working with each of these programs around designing, implementing, and evaluating evidence-informed strategies for managing domestic and sexualized violence within that complex intervention strategy I showed. We also work in partnership with executive leadership, in part demonstrated by our principal knowledge users, who are the vice presidents of clinical care at our two health authorities. And of course, in partnership with our advisory and working groups as well. Now, in order to carry out this work, we've had to scaffold how we're working with programs, mindful of opportunities for scaling out, so trying something in one program that could then be translated to another, and also looking at programs' timelines and priorities and our capacity as a team. So the programs that we've been working most closely with to start include public health, maternity and childcare, and the violence prevention program. And again, happy to speak to a little bit more what that work has looked like. But generally speaking, we're using a mixed methods, multiple case study design that is using or informed by intervention and implementation science research frameworks, including the Medical Research Council framework around design and evaluation of complex interventions. In terms of where we're going from here, we are carrying out intensive planning, implementation, and evaluation that will continue at our scaffolded paces with our programmatic partners across the next year. And while we have program-specific outputs that will be coming out from our work with each of these programs, we are also focused on producing a cross-system research output that looks at how do we transform a health system's response to violence? And this has rarely been produced in the literature. We very often have these kind of micro-level examples of specific hospitals or specific program areas or disciplines that have taken up different violence prevention and response strategies, but rarely have we had the opportunity to look across a jurisdiction's health system at how we can take all these different pieces of the puzzle and bring them together to more effectively respond to violence in a coordinated approach. So that includes not only the process, but also the contextual factors that are at play, both in terms of barriers and facilitators, and the data that we need to evaluate our progress and impacts. So finally, to wrap up, what are the takeaways, both for violence prevention, but also just complex health problems, more generally speaking? In the case of gender-based violence, including domestic and sexualized violence, of which intimate partner violence is the most common, these are critical health issues, and health systems have an obligation to respond. The obligation is there because it has been shown time and time again that this is a critical public health and population health issue that if we leave it unaddressed is going to continue to have severe negative impacts on population health and well-being, and importantly, health equity. However, the capacity of our systems to take up this work is limited, especially in terms of institutional supports and barriers. To address this, we've been using a number of best practice implementation strategies to build engagement, momentum, and sustainment across evidence-based activities. Now, this is in a context in which the provincial government has declared this as an epidemic, in which health authorities and government and community organizations and social services have been tasked with recommendations specific to violence. We still face many barriers to moving forward effectively in this work. So some of the few, and this is just an example of strategies we've used, are local needs assessments and intensive education around the findings, identifying and building up champions. So not just finding those champions, but continuing to empower them with information and also strategic partnerships, creating advisory groups and working groups to help take up the recommendations of the work and inform those recommendations. In CIHR's language, strategizing win-win solutions is a huge strategy we use. And I think importantly, when you are working on a health problem that is complex, that requires many resources, and in many cases might be marginalized by the system itself, it's refusing to accept the status quo. And that forces you to continue to be creative in the strategies that you adopt and attempt. I also want to acknowledge too that we're building on existing resources. This is investment from the government. This is investment from the health authorities wherever possible. So this work lives on beyond my team's current grants. Also want to highlight that when you are dealing with a problem of this complexity and a cross-system response, you very often need to work with partners outside of the health system. And so a lot of the work to date does include partnerships with our intersectoral organizations and knowledge users so that we can effectively put forward a strategy that might start in the health system, but it ends in the community. Thank you. And of course, I want to acknowledge all of our participants, partners, and collaborators who have made this work possible. And happy for anyone to connect with me over email. And again, encourage you to check out our website. Thanks.